The, S- the SFM observes the Spina Bifida Awareness Month, and we have a webinar lined up where we'll have a didactic lecture followed by a panel discussion. Spina bifida, well, we know the incidence all over the world is about 1 to 2 live births, but in India, it's quite variable. And that's quite variable because we have 60% of the rural population, and therefore the incidence varies from the north to the south. It's much higher in North India. So the least we can do is we can actually work towards identifying cases with spina bifida. Though we know that it is a preventable disease, we still do not have any national program specifically targeted towards prevention of spina bifida. We have the anemia prevention for adolescents where they give iron with folic acid, but we still lack a comprehensive program for spina bifida prevention. So the emphasis now should be to pick up spina bifida as early as possible. There are various lectures, conferences where they now talk about spine abnormalities. We know that with advancement in technology and better understanding, we can pick them up much earlier than actually taking it till term. But the whole emphasis now is to pick them up as early as possible. The Society of Fetal Medicine that is at the forefront of such educational activities where our outreach programs through webinars and through conferences, we have highlighted the importance of intracranial translucency. And we emphasize that we should start measuring the intracranial translucency because we know that the loss of IT is often the first sign of a spina bifida. So by measuring it, we are making sure that we don't overlook that sign, that vital sign of diagnosing them early. So to take us through the various signs of spina bifida in the first trimester, let's relearn that from the maestro, the mentor emeritus himself. Welcome, Khurana sir, and he will be elaborating all the signs of spina bifida in the first trimester. And this will be followed by Dr. Aparna Sharma and Dr. Alok Vashni, Dr. Rima Bhatt and Dr. Alok Vashni, who will take us to a wonderful panel discussion. Over to you, sir.
Thank you. A very good evening, everyone, and thanks, Mohit, for that wonderful introduction. We are going to start with that brief lecture that you mentioned on the diagnosis in the first trimester of spina bifida, and then move on to actually going on to the panel where we will discuss the management, of course, along with all the rest of the stuff. I just wanted to check whether there is any news of my, there it is. So do you see my pointer and do you see my slides?
Yes, sir.
Wonderful. So we'll go right ahead. And over the next 20 minutes or so, I will talk about the first trimester detection of neural tube defects to help awareness on what is the Spina Bifida Awareness Month, October, and also in advance of the World Spina Bifida and Hydrocephalus Day, which is October 25. And so we shall talk about today how we're going to be able to have research, education and support, clinical care network building and advocacy as guided by the Spina Bifida Association and the Spina Bifida Resource Network, because this is something that you and me need to be very, very aware of. We know it's a birth defect that's been affecting babies and their families for many centuries. And note I say here, affecting babies and their families, because really speaking, a disease like this is never born just by the individual, but has a very, very glaring impact on the entire community, if not just the family. The word was first used in the Netherlands in the late 1500s, and it means a split spine. And it happens during intrauterine life. For those who are going to be watching this on YouTube later on and are not professionals, they ought to know that this disorder happens in intrauterine life when the developing embryo that folds and rolls on itself does not do this along an organized, naturally predetermined pathway, and therefore a gap is left in which there is abnormal development of the nerves, abnormal development of the entire bony part of the spine, and abnormal development of the skin and muscle that overlies the spine. The location where this spina bifida happens will determine how it has an impact on the person, and a lot of functions can be impaired, which include neurological and motor functions, as well as problems with the urinary bladder and bowel. It's important to remember that with the proper support, people who have spina bifida can live full and happy lives. And therefore, when we talk of spina bifida in a clinical sense, we don't think of termination of pregnancy as the first option, because a lot of these individuals with the right kind of support can lead very fulfilled lives. So let me go right ahead and go through what I want to emphasize on, and that is a classification and a working list in the background of embryology, technology and tips on how to use various techniques and how they give us a diagnosis, and a brief atlas of some representative cases. And I will leave the counseling, the teamwork, the awareness of surgery, and general awareness in today's professional world to the panel discussion that will follow. Thankfully, we don't get to see too much of anencephaly or a large open spinal defect in neonatal practice anymore because of the advances in diagnosis, but occasionally we do get shocked. We've realized also that a banana and lemon signs have been proven to be useful over the generations, but thanks to the development of the nuchal translucency mid-sagittal scan, which is what you see here in the middle of this image here, we are now able to study the brain substance that exists between the nuchal translucency and the nasal bone and attach importance to it and come up with the diagnosis that yes, the spaces that we see here are not right, and we will discuss these spaces, because what truly happens is that depending on whether fluid leaks out of the spine or not, that is cerebrospinal fluid, you will find a collapse in these fluid spaces, which can be variable, and we will discuss that as we go along. Many children and adults today with open spina bifida do have a happy and productive life, and this must be kept in perspective, like I said. And the perception and comment about the possible fetal prognosis vary depending on every family social dynamics, as well as the cultural and economic environment, because everyone is going to look at it differently. For some people, every fetus has a life, and therefore they would never destroy a pregnancy. For others, they would realize that this does involve a lot of extra effort on the part of the individual, the family, and the community, and therefore needs to be looked upon differently. And the mission of clinicians is to actually provide evidence-based information so that all these families get the correct kind of guidance, which should not be directive guidance. Now, we do understand that it still remains India's commonest malformation, and the incidence has decreased over the years because of termination of affected pregnancies and increased periconceptual folic acid use. But please do understand that there is a residual amount of spina bifida everywhere, which is neural tube defects, but particularly in Bangladesh, Bhutan, India, and the People's Republic of Korea, as well as Nepal, we have double the incidence as compared to the rest of the world. So for us, the NTDs per 1,000 live births, and that does not include the ones we lose during pregnancy, would be 4.5 per 1,000. And it is presumed that about an equal number would be lost during pregnancy or be terminated because of that diagnosis. And therefore, we still need to talk about this in today's day and age. Also, that when we look at data from all over the world, this amount of residual disease that we find in spite of perfect folic acid rehabilitation and substantiation, we still have spina bifida taking place. And of course, what we're going to talk about first today is how to diagnose this as early as possible so that decision-making becomes easy. We do understand that in the first trimester, quite different from the second trimester, we do not have sequelae of this particular condition, and therefore we would only look for direct evidence of the defect and its indirect signs. Whereas in the second trimester, you end up also looking for its effects on the bladder, its effects on the movements of the limbs, and so on. We also understand that, yes, there is this trouble within the first 21 to 28 days of embryonic life, which means the first 6 weeks, really. And that there are many theories on how the neural tube is supposed to close, but that doesn't matter. The fact is that it doesn't close like a zipper from top to bottom, but it closes in various bits, and therefore you can get all kinds of combinations. The first question, of course, that everybody asks is, what's the hurry and why should we make a first trimester diagnosis? Well, the option that most couples seem to be taking these days is termination of pregnancy. And if that's the option, we know that the termination of pregnancy in the first trimester is easier, safer, and much softer on the psychology of individuals who have to go through this. Also, for mothers who have a previous problem, it's a very early reassurance. And on the off chance that we do discover something, then it will you have a longer window for a complete assessment for a genetic syndrome or just a plain non-genetic syndrome, and of course the risks of recurrence. So here are two cases. This one where there's a gross disruption of the spine, and we know that this will result in a huge amount of disability and probably hydrocephalus much before birth. And therefore, the decision here for most patients in our part of the world would be to opt for termination of pregnancy, although we would leave it completely open to them on what they wish to do. On the other hand, something that is as subtle as this may not be very convincing unless you were told that this patient actually had 2 pregnancies earlier that had neural tube defects, in which case you will know for sure that this is a 3rd neural tube defect. But if this was someone who was married only for the last 8 or 9 months and she conceived soon after she got married, then it's something that you might consider, well, I will terminate or not, and therefore then we start thinking of what's going on. Or worse still, if this was an IVF who conceived after 15 years, she might actually just carry on with the pregnancy. So the idea really is to give them enough time to decide what they really want to do. Technically, there is a quality of life issue with these, and therefore we could terminate them anytime later in pregnancy, but we should try and diagnose these as soon as possible so that the psychological impact is the least. The next question to be answered is whether we should do these at 11 weeks, 0 days, or at 12, or at 13, or at 14 weeks during the time. And we know that size matters. And here is a typical fetus at 11 weeks and 3 days. And this one is a fetus at about 13 weeks. And you can see that there's a huge difference in the anatomy. And we've been talking about this for many years now. About 20 years ago, we did publish that if you look at these babies between 63 and 84 millimeters of crown rump length, and you use a transvaginal scan, you will actually pick up almost half these abnormalities. And if you added on 3D and 4D, you would actually pick up a lot more and pick up almost 4 out of 5 of these abnormalities. Yes, it might interfere with the accuracy of your papae, but that papae still remains pretty sensitive at 12 to 13 weeks. And therefore, it seems like the sweet spot is at about between 12 and 13 weeks. And the later, the better for anatomy. The next thing to understand is that technology is very central to this whole thing. And it's not enough just to look at skin covering. It's also not just enough to look at bone. You need to use a combination of both. And that we really need to be making sure that we use the right technology. And we will discuss this today as we go along. When we decide whether to do a transabdominal or a transvaginal evaluation, we must understand that the transducer is difficult to manipulate if you're having a transvaginal evaluation, but the anatomy is far better. So typically what I would do is to look at the transabdominal view to get an overview, to look at general abnormalities, as well as for my nuchal translucency in the crown rump length. But I would also make sure that I have the availability of a volume transducer, because that'll give me more information, and that my transvaginal scan would be used anyway whenever I have a doubt or whenever there's a clinical pointer or an ultrasound pointer. And therefore, then I would look at anatomy very, very carefully. And then again, I would use a 3D transvaginal transducer. And you can see the difference for yourself. Here is a fetus where the butterfly seems all right. But when I go down to look for the aqueductus sylvius, I seem to be picking up 2 parallel hypoechoic lines. And the first thing that comes to my mind is, yes, can this be the parallelism of the cerebral peduncles in spina bifida? And then I go back to my view, which is my mid-sag view, and I realize, yes, there is a thickening of the brainstem here. a disappearance, a near almost disappearance of the actual IT, the intracranial translucency, which is the fourth ventricle, and a near complete disappearance of the cisterna magna. And the brainstem, like I said, is thickened. When I look at it in the axial view, this little dot is all that remains of the aqueductus sylvius, and it has moved much closer to the occipital bone than usual. Then I start looking, and whether I use an older rendering engine on 3D or a newer one, I'm able to realize that yes, there is a gibbous, that the vertebral bodies and their appendages are grossly disorganized, starting from the lumbar area, and that disorganization goes all the way down to the sacral area as well. Therefore, then I have a full diagnosis of an open neural tube defect. Now, when we try and use even further techniques, for instance, if I were looking at a mass at the back of the neck, query cystic hygroma, query meningocele, then I could use an advanced 3D technique which converts all fluid into color or just into one inverted color. And then I can show that, yes, indeed, there is a herniation of the entire content of the cisterna magna out below the skin, and that's an early meningocele sitting in the cervico-occipital region. So sometimes it's possible with simpler techniques, and sometimes you need to use all the technology that you could possibly lay your hands on. Please also remember that when we look at these situations, it's important to, again, even in these younger embryos, just like we look at the time of the 20-week scan, to try and look at the entire skin and try and trace the actual spinal cord, and it is possible. So here is a situation which was pretty much obvious at the 20-week situation, but all these findings of a seal being there and of a mass covering everything are there at the time of the earlier scan as well. There's no doubt that, yes, the incidence is much less now, but that is important to remember. One sad fact which you and me must be aware of is that it is important to emphasize that there's an increased risk of neural tube defects in obese women. And this risk shows a positive linear correlation with increasing degrees of obesity. Now, that's a major problem, because this means that in obese patients, we may not be able to visualize the spine and the cerebellum as well as we would like to. And therefore, we need a much higher level of attention to make sure that we're looking at these carefully in spite of the degraded acoustic window. Now, because of the fact that we have so much polycystic ovaries, so much abdominal obesity, and yet we have so much neural tube defects, also we need to draw a definite balance and make sure that we never let a lesion go just by saying it's probably okay. There is no probably okay. It is either okay or it is not okay, and we must work towards that. There are a few more home truths in this, and that is that, yes, it's an easy diagnosis at 19 weeks because of the indirect signs, but it's not such an easy diagnosis at 12 weeks. Also, that we've been using maternal serum alpha-fetoprotein and ultrasound at the time of the 20-week scan, but we cannot use the AFP early. There is a test, the first trimester quadruple screen, which uses alpha-fetoprotein, but it's not as sensitive at all, and really is to be used when imaging is not of good quality. That is how Howard Kuckel perceived this test, which came from PerkinElmer many years ago, and therefore we must realize that just as it has been dropped from the second trimester, it should be dropped from the first trimester as well. Now, there are some very good guidelines, and these are available from the Canadian guidelines of the Society of Obstetrics and Gynecology of Canada, and they were printed out in 2021 and are still relevant even today, and include diagnosis plus prevention plus screening, and we would be discussing this during the rest of the webinar today. The primary screening test, as they suggest, is always an ultrasound scan, and maternal serum alpha-fetoprotein is only to be used in people where you really have a doubt about the BMI. Otherwise, it's not something that is to be used routinely. Now, I'm going to use this chance to also talk about the classification, and there's a very simple working classification, and this has nothing to do with the 653 other classifications that we have. Basically, it's either cranial or spinal, and open or closed. When we talk about open or closed, we're talking about a situation where the defect is covered by full thickness skin or not. When we look at the cranial ones, we have anencephaly with the brain missing. We have craniorachis with an open brain and open spine. And we have a focal open spina bifida where the skin is not complete, which is why it appears pinkish like you see here. If the skin is complete, then that becomes a closed spina bifida. Then you have, of course, the encephaloceles, which could be anywhere, and anencephaly, which is really a defect of the cervical spine, but some people tend to include it as a defect of the craniocervical spine. But really speaking, it's as simple. If there's full skin thickness, fluid will not leak out and it behaves like a closed defect. And if there is thinning of the skin or no skin at all, then that behaves like an open neural tube defect. So a meningocele with full skin would be closed, and a meningocele with thin skin or no skin would be open. And this is a close-up of the same thing. So here we have just a little distortion of the vertebrae, a low-lying cord, and that then becomes an occulta because the skin is complete. Here you have fat in the seal, you have an entangled cord, but there is a full skin, and therefore then this becomes a closed spina bifida. And here there is only fluid, but entangled cord, and this is still a closed lesion. But if that pink line were not there, as you see, it's not here, then this appears as a pinkish cover. And that's something you will see as a non-continuity of the skin, even on ultrasound. And that then becomes an open defect. Now, there are lots of names that have been used in literature, and we should try and avoid these, except to remember that, yes, there is also one type, which is a sequence, which means you have an open brain, which then gets worn off gradually. At that stage, it's called an exencephaly, and then finally gets worn off completely, and that's called the anencephaly. So it's not that all anencephalies have this acrania, exencephaly, and anencephaly. Some of them are just pure anencephaly anyway. Now, please do remember that it's not possible most of the time to make a good diagnosis before 13 weeks because you don't see the spine so well. Of course, sometimes you can. Also, when we look at the spine very early in pregnancy, we do understand that to be able to see the appendages is not so easy, and therefore we will very often not see the actual defect. And for this reason, it's been realized that whether you use 2D or 3D or any other D, the real method to be used is to look for indirect tests, which is known as screening. In this particular type of screening, we use the nuchal translucency frame, and we find that there will be alterations because of the fluid oozing out, so that the brainstem will undergo a change in thickness and location. It will also move closer to the occipital bone. And these spaces, the intracranial translucency, labeled here is the fourth ventricle, and the cisterna magna would reduce in size, so that you won't find this sequential arrangement as you see here. Sequential arrangement meaning that the brainstem is thicker, then you have an intracranial translucency, the yellow one, which is medium, and a cisterna magna, which is the gray one, which is the thinnest. There have been lots of signs, and the reason there are lots of signs is that no particular one sign is actually 100% diagnostic. These are all screening signs, and they've been discovered as we've gone along since 1997. And these include a demonstration of the actual defect, a reduced or absent intracranial translucency, a thickening of the brainstem, a shortening of the distance between the brainstem and the occipital bone, an increase in the ratio of the brainstem diameter to the brainstem occipital bone distance to greater than 1, and usually about less than 0.9 would be the usual. And then in the axial view, you can get a posterior shift of the midbrain with parallelism of the cerebral peduncles, a decreased BPD, a reduced facial angle, and the crash sign, which really is the same as the parallelism as we see it. Now, the intracranial translucency is something we measured in Indians also many years ago, and we published this about 10 years ago, and we realized that yes, it's the same in Indians as it is all over the world. And of course, here is a graphic representation of what we see: a thick brainstem and obliteration of the spaces at the back of the brain. Now, when it comes to a recognition of this, you have to keep on non-stop realizing that in literature, some people refer to the white lines and the black spaces, and some call them just the black spaces. It's essentially the same thing as a thickened, displaced brainstem. Remember that this old Indian data is pretty much applicable even today. And the findings, of course, are now superseded by the fact that you can actually see the pathology. So the abnormal brainstem to occipital ratio here, it gets altered, and you can see that you have a much thicker brainstem, a much thinner intracranial translucency, and a much thinner cisterna magna that you would expect. We also realize that in this situation, in this area, the orange area, we must start looking at it in every NT view and make sure that we don't miss this. Also, the fact that the entire brain stem moves backwards and downwards, and therefore you can actually pick that up as well. And this was also defined by Simon Ma and his group. And they clearly told us that if you draw a line from the top of the palate all the way to the back, you will find that in spina bifida, the junction between the actual midbrain and the brainstem is below the line, as you see in this particular one. So that's the palate, and you've drawn this line to the back, and the brainstem is here. It's displaced below, so that the junction between the brainstem and the brain and the midbrain is way below that gray line instead of being above that line. The parallelism, and this is the case, this is the normal appearance of the aqueductus sylvius, and that space gets obliterated, and that dot of an aqueductus sylvius moves very close to the occipital bone. And then, of course, you see here those parallel cerebral peduncles, and it can be very well seen with a transvaginal scan as well. Ferdushakov made this into a crash sign, but essentially it's the same as describing the parallelism, and you can have different degrees of thickening of the brainstem. There's one new finding that's been described recently in 2021, which shows that if you were to use color and look at the junction of the superior sagittal sinus with the straight sinus, and most of this work is then done abdominally because that's easy to manipulate, then you will find that on grayscale, the angle will be almost like a right angle in normals, and in open spina bifida, that angle becomes pretty much an acute angle. Also, the normal configuration of this junction between the superior sagittal sinus and the straight sinus is U-shaped, and it becomes displaced caudally and V-shaped when you have a neural tube defect. So that is something that you and me should be aware of. There is also one article from India many years ago from Dr. Suresh's group, which emphasized the low BPD. And in this, what they did was to calculate the MOM of the BPD based on the abdominal circumference. And they showed us that the 10th centile is a good way of trying to pick up almost 63% of the open spina bifidas, and it seems to work. When we look at the rest of it, the anencephalies are easy to see, the typical frog eye and the leftover brain at the top of the brain there, floating around in amniotic fluid. When we look at acrania, the brain has a normal, almost normal appearance for a while, and then gets worn off, as you see in this particular video over here. And this is almost like an exencephaly. And then as time goes on, you will then pick up the disappearance of the brain. In anencephaly, the grayscale findings are hyperextension of the neck and fluid loculi on the sides of the neck. And the 3D is very convincing. You find a completely crooked, hyperextended neck and a lot of soft tissue in the front and the sides of the neck. And that is a straightforward diagnosis of the star-gazing fetus. Remember that most encephalocele, if they're large, will be picked up, but some teeny-weeny ones will not be picked up. And we will discuss these as we go along. But the most classical sign, once you spot the indirect signs in the brain, would be to look at the lesion itself. And then by working hard on it and doing a transvaginal scan, you'd be able to identify this both in 2D and in 3D. And the 3D is more convincing in terms of diagnostic confidence. We must remember also that sometimes these open ones can be quite confusing, but you have to look at it in 3D with a nice ridge. And as long as you're following the nice track appearance of the two, and if there's any disruption and you use that as a sign, you will not miss any of these lesions at the back of the spine. Can we do this before 12 weeks? And the answer is yes. You can pick up the spine as early as before, but not always. But what you can pick up if you look carefully, even in dead embryos, is the fact that we can at that time find out some of these findings. And let me show you an example. This, of course, shows some of the other stuff that we picked up before. But the fact that even in a dead embryo, this is the umbilical cord, and you see it at this end, which means this is the tail end. This then is the head end, and instead of having a round head like this one, this is the normal cranium, this is the abnormal one. You would have then identified acrania as early as 8 weeks, and then the products of conception would therefore then identify for the need of genetics. And of course, there are some normal variations that you find at this time, which we can't label as spina bifida, and one of these is a very round globular rhombencephalon or a large aqueductus sylvius, which we find always at 10 weeks and are not be mistaken for abnormalities. So the possibilities here, as you can see, are something that we must be aware of. And then we will go on now to the panel discussion, where we'll discuss some of the genetic bases, the large number of causes that you have for these conditions, the prognosis and how to evaluate that, as well as how to differentiate between the spinal level and the neural functional level. And therefore, my message that you should take home from this is that we have these as common in the Indian scenario. We must do a 12-week plus scan, which is usually frequently conclusive. And then if you have a doubt, you can do an early second trimester scan at about 14 weeks in obese patients and at about 17 weeks in non-obese patients. And you need to follow a cranium and spine evaluation meticulously. And thank you so much for your attention.
Thank you so much for such a lucid presentation, including all those statistics. If you have any questions, we can probably take, or maybe we'll keep it for later on.
Yes, I think
so. To the great presentation now. I now welcome Dr. Reema Bhatt and Dr. Alok Vashni to introduce their panelists, as they will be moderating this panel.
Thank you so much, sir, for that glamorous presentation. And I think there's so many take-home messages and beautiful videos. We now move ahead with our panel discussion. To take you through this, I have my dynamic co-moderator, Dr. Alok Vashni, and wonderful panelists, including Dr. Mohit Shah, Dr. Aparna, Dr. Chinmay, who need no introduction. Dr. Anurag Sharma is a pediatric neurosurgeon at Amrita Hospital. So, Dr. Alok, I would request you to kindly take us through the cases.
Yes, thank you so much, Dr. Reema, for introducing the panelists, and thank you for including me as a co-moderator. So we'll jump right away with the cases. So we have 4 cases planned. We hope that they'll cover the spectrum of the spina bifida. So first case is she's a 24-year-old priming gravida. The previous examinations, including the NT scan and combined first trimester screening, they were reported as normal. And then the patient presented for an anomaly scan. So next slide, please, Dr. Reema. So Mohit sir, please, if you can look at the case and describe the findings that you see.
It's the first thing that strikes is the ventricular megaly. You have ventricles which are dilated. You see the choroid plexus dangling. The posterior fossa is effaced. You see the cerebellum quite, you don't see the cisterna magna at all. You see the banana cerebellum. So, and the one thing is you don't see the third ventricle too well, not dilated there. This is classical of a herniated brain. So this is intracranial changes of a possibly a spinal defect there. You see the cerebellum quite evident there. Oh, that's the longitudinal and the transfer. Now this is interesting. You don't see anything bulging out there. You see widening of the posterior elements, but nothing is bulging out. This is as if that entire nuchal placode is flush with the amniotic fluid. So what is typically called myeloschisis or myelocele, where the neural placode is flush with the amniotic fluid. There's no protruding element like a meningocele or a meningomyelocele. It's that entire spine which is open to the neural, to the amniotic fluid.
So you've already described the findings here. So we see the cranial signs, and we also see a large open neural tube defect involving multiple segments in the spine. And it is open, the skin overlying is absent, and the posterior elements of the spine, they are widely splayed. So these findings are very consistent with myelocele, in which the spinal cord itself is exposed to the amniotic fluid. And because it is involving multiple segments, not a few, so we can consider this as a rachis. Next
Yeah.
slide. Yeah, so you can see in the 3D that a very long segment of the spine.
Beautifully depicted on 3D, yes.
Yes, so
This is why I think 3D helps to give you a better perspective of the spinal defect rather than 2D alone. That's a beautiful 3D reconstruction.
thank you. So Dr. Chinmay, yes, you are up. What is the incidence of open spina bifida, and is the incidence on the decline? Do you see many cases these days? And do you think that these are preventable defects?
Very good question, sir, and I'm sure a majority of it has been answered by Mohit sir and Khurana sir. But as the slide depicts over here, the incidence is quite varying, and we as a country are not doing as well as our Western counterparts are. Our incidence is at least double that of the others. And of course, as many as 70% of these defects can be prevented by simple folic acid. I think the problem here is twofold. One, as you rightly suggested, maybe fortification of food may help, but more importantly, supplementation of folic acid, at least 400 micrograms to around a milligram, should be advocated to all the women who are planning for pregnancy. And I think that is where we as a healthcare system and population are failing, because majority of our pregnancies, even in the educated class, are still unplanned. There is lot of confusion about good contraceptive measures, and thus many people still are turning up with unplanned pregnancies where they do not get adequate folic acid supplementation at least a month in advance of their pregnancy. The second problem here, apart from contraception, is I feel the role of L-methyl folate. You must be coming across so many commercial preparations these days which contain not folic acid but L-methyl folate. And although the data, very limited data, suggests that it could be at par, there is no substantial evidence that L-methyl folate is useful in prevention of spina bifida as good as folic acid. So if you go by National Institute of Health recommendation, we should still be giving folic acid to those people who are given L-methyl folate for medical reasons. So I think these two problems together are kind of combining, and they're somewhere we are failing to prevent the preventable.
Thank you so much, Dr. Chinmay, for this elaborate answer. And we'll jump right ahead to the second case. And this is again a G2P1, 18 weeks, 5 days pregnancy, and combined first trimester low risk. NT scan was also reported as normal, and the patient presents at the time of anomaly scan. So again, we see the typical cranial signs. We see lateral ventricle dilated, mild hydrocephalus, cerebellum draped around the brainstem. It is small in size. Next slide, Dr. Rima, please. And when we look at the spines, we see these defects. So Mohit sir, can you please describe what we are seeing here in these images?
So interestingly, both these cases, these were not picked up in the NT scan when it should have been. But one striking feature here that I would like to highlight is this is a reason why you should have a spinal evaluation when the spine is not abutting the placenta or the uterine wall, because you see this tiny cystic lesions which is at the fag end of the sacrum. So you have this very thick-walled cystic lesion which is protruding from the sacral spine. But more importantly, you see the spinal cord components extending into it. And you see the spinal cord is low and it is extending into the defect. So this is not a simple meningocele. This in fact is a myelomeningocele, because you can actually see the nerve roots extending as and appearing as septae within that defect. So that's a terminal sacral meningomyelocele.
So absolutely correct. So is this an open defect or a closed defect? Because it seems to be covered. There's a membrane cystic structure which is there.
So this is an open defect simply because having a membrane is not sufficient. When you say a covered defect, you have to have the subcutaneous tissue, the fat which goes along with it. And if we have any defect, maybe we'll have a better perspective. But we look at the subcutaneous fat that goes along the defect, call it a skin covered defect.
That's absolutely right. So these are the typical intracranial ultrasound findings that we see. We can see lemon sign in almost 100% of the cases, banana sign in 96% of the cases, and the other findings like a small biparietal diameter in about 62%, head circumference can be smaller. Ventriculomegaly can be there in 54% or nearly half of the cases. Sometimes it can develop later on also. And almost all these cases, they have obliteration of the subarachnoid spaces because the CSF leaks out from the open spinal defect. So if we look at the classification, so these open defects, they can be without cyst, which are the cases with the first case that we saw without any cystic lesion. So the neural placard is not elevated. So these can be the myelocele or myeloschisis. The prognosis in these cases is better. But majority of the cases are there in which the neural placard is elevated. It is flush with the membrane, or it is so the prognosis in these cases is worse. And we know that most of the cases are there lumbosacral and followed by the sacral components. So these are the diagrammatic representations that we can see of the various open defects. So there can be meningocele in which there is just a protrusion of the meninges out from the defect. And these sometimes can be skin covered also. Meningomyelocele, the defect is open. We see protrusion of the meninges plus the herniation of the neural elements and the neural placard. Myeloschisis, the skin is flush with the osseous defect, and the neural elements, they're exposed to the amniotic fluid. And this is the typical myeloschisis with it, which can be there with neural placard elevation also. Next case, please. So you've seen the case. So what additional findings aside from the cranial spinal abnormalities should we look for in ultrasound examination, keeping in mind the prognostication?
Well, the most important thing is the level of the degree of ventriculomegaly. But then apart from that, what we should be concerned about is if the lesion is very high up, then I would be worried about lower limb movements. So what I should emphasize is looking at the lower limb movements in real time and look for any flexion or fixed joint deformities. Even CTEVs for that matter would be a sequelae to a high placed lesion. So that is more important for us to see. The bladder bowel becomes more relevant postnatally, of course. But yes, lower limb movements are something that we can safely rely on, especially when the lesion is high up.
True. So many of these cases, they can have this talipus, equinovarus, rocker bottom foot, or arthrogryposis. Fixed contractures can be there. And we should also evaluate for any extracranial, extraspinal abnormalities also, because these can be part of various associations, the Vectral association, etc., etc. So, Dr. Chinmay, would you advise MRI in such cases? Would you recommend MRI?
Not routinely, sir, because the scan is as good as MRI if the machine is with the right person, and majority of the information you require, you can acquire it through the scan. So MRI may be reserved only in cases where the body habitus is limiting the exposure of the fetus.
True, perfectly true. Dr.
So, yeah, so we want Dr. Aparna to let us know that how do we determine the level of the defect and is it important?
Yeah, hi. Hi, everyone. Very good evening to all. So yes, I think this is one of the most important factors which actually determines the postnatal outcome. Uh, and how the baby is going to do, because whether it is the motility is affected, whether it is the incontinence, how is the quality of life going to be, it depends a lot on the level of the defect. So essentially, we really have two ways to do it, but we generally start counting by the lowest ossified vertebra, which is the S4, and we start counting backwards. And then, of course, the lumbar vertebra. So usually what we call the sacral lift. So the point where the sacrum starts, that's a little elevated, and that's how we identify the sacrum. Then, of course, there is this method where we draw a longitudinal line through the sacrum and the lumbar vertebra, and the point at where they meet is the S1. So essentially, on the face of it, when you are actually imaging the spine and you feel the place where there's a slight amount of tilt towards upwards is the place where your sacrum is starting, and that's S1. And that's how you see. The other method, of course, is T12 is seen by the last rib. So if you are doing a good 3D and you're identifying the last rib, so that's the T12, and then from there we can count when we do that. And of course, as we said, anything which is the lower, the better. So the higher the motor disability sets in. So the lower ones involving the lower lumbar and sacrum may just have the incontinence, of course, but the mobility might be there. And that's where we also see the movement of the limbs when we are scanning to see the level and also the affection.
Thank you, Dr. Aparna. So it's very, very important that we know the lesion, where it is, the extent of the lesion, open or closed spina bifida, whether carry 2 is associated, if the head size is more than 38 millimeters. All of this translates into the survival, into motor function, the requirement of orthosis, wheelchair, dysphagia, incontinence, and requirement of shunt post-delivery. So it's extremely important to know where our lesion is and how we prognosticate it for the parents. Thank you so much. So, Dr. Aparna, we've had this MOMS trial for so long. Could you just tell us a little about this MOMS trial, please? What is this MOMS trial? You have to unmute, Dr. Aparna.
So sorry. So this MOMS trial is something which has been around for some time, and now it is increasingly gaining importance. So in the MOMS trial, essentially the fetuses with myelomeningocele were randomized to either undergo a prenatal surgery before 26 weeks or a standard postnatal repair. And the primary outcome was to actually see if there is any improvement in the neonatal survival and need for placement of CSF shunt by the age of 1 year, or otherwise, what was the neurodevelopmental outcome by the age of 30 months. So they were decided that they would want to do around 200 babies. The trial ended with 90 babies each in each of the groups. And it was seen that the requirement for the postnatal application of shunt was significantly less in the infants who underwent the prenatal surgery at 1 year of age. And also it was seen that there was significant improvement in the composite mental development and motor functions at 30 months of age. So what they really concluded is that prenatal surgery reduced the need for shunting and improved the motor outcomes. However, the inclusion criteria was something which was important because they actually took the babies who had between up to 26 weeks of gestation and located between T1 and S1 with evidence of hindbrain herniation and with a normal karyotype. So when all of these criteria were met and they underwent a surgery by the trained surgeons, the outcome was better. So I think this is something that is increasingly being done across the world and is now accepted that possibly if it is available, it should be offered.
Thank you so much, Dr. Aparna. So I think it's time that we move ahead with in utero surgery for myelomeningocele. We definitely realize that the placement of shunt is reduced, hindburn herniation is reduced, babies develop better. So I think it's time to move ahead. And even a decade after the MOMS trial, they found that there has been benefit to these school-age children, followed the children who underwent in utero surgery. They definitely are doing better even a decade after their surgery. So my question to Dr. Anurag Sharma is that If prenatal surgery improves the outcome, what should we opt for? Has it to, I mean, we still are contemplating in our country to start this procedure, but is open preferred or fetoscopic is the way forward?
Answering to the first part, yes, it does improve the prognosis, and mom's trial have proved it beyond any doubts that it's a standard. It's very strange why it's not happening in our country till now, because most of the in North America, Europe, and even in South American countries like Brazil, this is being offered normally to the patients. Coming to which is open and fetoscopic. So initially when we started, it was all open repair only. Correct. So when we got the mom's trial, initial part was done by most of the surgeons. They did the open procedure, and as you know, we are getting better with better technology, better instruments, and fetoscope. People were, since they went on trying, and now it has been proved that even fetoscopic surgery is as safe as open fetoscopic surgery. In fact, it's better in many ways, in the sense then that the theoretically at least the chances of premature labor, it's must reduce, because you're not handling much. You're not taking out much of the amniotic fluid, and you are able to repair this thing. So depending on that, what should be offered, I think it's a surgeon's expertise. The team is confident that they can undertake the fetoscopic surgery. Then, of course, a fetoscopic surgery should be offered. But they are both equally. I would not say that it is superior. It just depends on the training. I think that the centers who are starting, they should actually be starting with open surgery to gain confidence, because not all cases will they be able to do through fetoscopic surgery. So having the open surgery should be there, but yeah, I mean, with good training, both are equally effective.
Right. Thank you, Dr. Anurag. So I think the way forward is that we have to move ahead with the surgery in utero than postnatal repairs. And the post-surgery improvement, the children who underwent, the babies who underwent in utero surgery, they had a better MRI post-surgery, they were walking better, and they had improved neurological outcome, their motor function was better, they were less wheelchair bound, they were walking independently, orthosis that was required was lesser for these children. So I think it's the way forward to go ahead with in utero repair. That should be the standard of care even in our country. So, Dr. Anurag, you've been handling a lot of these babies post-delivery. They come to you for surgery. And how much are you able to offer in terms of their post outcomes when you offer these surgeries to these babies?
So, comparing postnatal surgery, see, it is a standard which we have been doing since ages. As already mentioned, the disease can be different. It can be only plain meningocele versus meningomyelocele with the placode coming out. So it becomes to the location is very important, because the occipital lesions they fare less better. The lipomeningoceles, they do extremely well. Similarly, the meningomyelocele is slightly complicated, but everyone has got some or the other restrictions. So especially the most important prognostication would be if the kid is having any neurological defect pre-surgery or not. And many of these kids, they have some amount of lower limb movements are restricted or not able to move. The first thing which we look for, because the function which is not there, it's very, very difficult that post-surgically that function is going to get better, or improve after surgery. We do postnatal surgery unless it is the impending rupture. We try to wait till about 9 months of age, when the kid is more stronger in terms of that to undergo surgery and hold losses during the surgery. Since there's no comparison, it needs to be done, then it needs to be done. So I would say that, does it affect outcome? Yes, because quality of life because some of the meningocele sacs are so big that the parents have very difficulty in managing the kid, because they have to place on one side, then they have to place on the other side. So cosmetically, apart from cosmetically, I'm saying even the functional, the way the family can hold their kids, it differs. So yeah, I mean, it's a routine thing. How much outcome? No, it's best thing. It should be that it should not have happened. So I agree
Yes.
to what Chinmay has said, that that we have to work on that level where we can educate people in planning. Then we should try to do go to government to support, because for the fortification through folic acid, then even make people aware, that they should always plan a pregnancy, always plan pregnancy, because it should
Yes.
not happen, because people are not aware. They think that once they are pregnant, then they start taking folic acid, least realizing that what has to happen probably has already happened. They by
Right.
the time they
Right.
realize they're pregnant, it's
Thank
already
you.
there.
Right. Thank you, Dr. Anurag. So it's the baby, once you operate, is always your baby, because till teenage years you have to follow up these babies, and it's not the task is not finished just with surgery. It's a long-term rehabilitation that's required for these babies. Dr. Chinmay, how would you counsel the parents for their next pregnancy? I mean, that's something very, very important.
So here I would like to be very clear with the couple and to myself that the gestational age doesn't really matter. Now, with the new MTP Act and the provisions which even Aparna ma'am and the likes of us have done in it, it is very, very patient friendly. And patients have enough time to make a decision. Gone are the days when they were under pressure to make a decision. They have enough time. They need to understand what NTD is like. They should not be taking emotional decisions. They need to know that, all right, majority of these babies are going to have disability. As we discussed, some of these babies could be eligible for a surgery. Surgery may not be available right now in our country, but there are neighboring countries where it is available and it can be managed very well. Having said that, it is also important to remind ourselves that those 30% spina bifidas where folic acid did not play a role, this could be one of those. So a very detailed family history up to 5 generations, understanding whether there is consanguinity, and also understanding if there is family history of neural tube defects is very, very essential. And it is very easy to lose out on those details because majority of the times in our country, those babies do not survive. So we may forget about them. So it is important, as the slide depicts over here, that if there is a first or second degree relative, please keep in your mind that this may happen again. Do reassure the patient that once of spina bifida unlikely to recur, chances maybe only 1%. But if it has happened more than once, then the recurrence risk is significant and the need for genetic testing and counseling becomes much stronger.
Right. Thank you so much. So if there 2 or more pregnancies, the risk of recurrence could be as high as 10%. So we really, really need to be careful with these patients. Dr. Aparna, would you advise any genetic testing? And do you think that there is role of MTHFR gene mutation in these babies who develop neural tube defects?
So as a clinical practice for the first neural tube defect, or if it is like a single neural tube defect, we generally do not advise any genetic testing because we know that there are a lot of extrinsic factors which are non-genetic factors. So of course, the nutritional factors, while we do understand that there are other factors, like of course, folate deficiency remains one of the biggest factors. Then of course, there are other environmental issues which can, really cause these neural tube defects. But the important thing is that eventually, if you look at the molecular level, there are some genetic changes which do affect the expression, leading to the folate deficiency in the body, leading to the neural tube defects. But what is the point of genetic testing is, are we able to establish some recurrence? Are we able to provide a solution? Is it going to make any difference in the management? So as a rule, we do not offer any genetic testing if it is the first defect. However, if it's a recurrent neural tube defect, then of course we need to look into if there are certain candidate genes. In fact, a panel of 191 candidate genes have been identified which result in familial or recurrent neural tube defects. And I think that is the point where we should start doing the testing. But for a single event, we would attribute that to folate deficiency. And even if you do have MTHFR mutation, your treatment will remain folate supplementation. So I think that is the thing that we should follow. Unless it's a recurrent defect, we should not really think about genetic testing.
Right. Thank you, Dr. Aparna. So there is no role actually of MTHFR. It is all multifactorial. But we need to understand that if there is something associated like an occipito-encephalocele. We could be looking at Meckel-Gruber or Walker-Warburg syndrome. If there is there could be Jaco-Levin syndrome if it's which is an autosomal recessive, but then the spinal condition would be different, a disorganized spine, multiple segmental defects. So all of that will be present. But per se, there are no major genetic associations with isolated neural tube defects. So Dr. Alok, could you take on the next case?
Yes, so coming back to the cases again. So this is the third case. And again, we see the typical findings. So we see ventriculomegaly. Again, we see the small cerebellum, which is again draped around the brainstem. Cisterna magna is obliterated. So next slide, Dr. Rima. So here we have something new. Mohit sir, can you please look at the case and describe
This
what you
is
see?
a very severe form of kyphoscoliotic deformity. And if you look subjectively, the spine also appears shortened. So apart from that, you have fleetingly saw an open neural tube defect jetting out there. So this is a completely kyphoscoliotic lumbosacral spine with an open neural tube defect there. I could see it fleetingly at the end of the loop, I believe.
So we can see it better in the axial plane. Dr. Rima, can you please? Yes, so
Yeah,
in the axial plane, you can see the neural placard is elevated and it is
yes.
exposed to the amniotic fluid.
Yeah, and you see a curvature abnormality, persistent curvature abnormality there. Nicely depicted on the 3D there.
True. So we also see the limb abnormality. There's a rocker bottom foot we can see. Next slide, Dr. Rima. So Anurag sir, do you think with these findings, these additional osseous findings, do they change the management and can postnatal surgery improve the outcome in these cases?
So we if the kid is symptomatic, then we have to offer surgery. But outcome, I don't think, because in case of severe disease, there are always going to be certain deficits which are going to persist. What we are going to do is we are going to make the neural tissue safe. We are going to push it and we try to detether, which it has got again its own problem. But as the kid is going to grow, retethering is something which might happen. And we cannot have any big surgery or bony handling for these young kids. So the more severe the disease, the more bad the outcome is.
True. So this is the last case, and this is a little atypical case that I saw a few, I think, last year. So Mohit sir, can you describe what you're seeing here?
Well, I see the cerebellum nice and clear. I see the ventricles are nice. The cisterna magna is slightly smaller, but it is seen there. And I don't see any scalloping, no signs which are very conclusive to say that there could be a spina bifida here.
So, but because it's generally we see the spine in all the cases. Yes.
Yeah,
So here you can see there's a defect, and we can see a cystic structure in the lumbosacral region, and we see that it is compressed between the uterine wall and the spine, and it is visible only when the fetus moves away.
Right. That's very important, very nice. This is a fantastic pickup, by the way, Dr. Alok, because it's flush with the uterine wall. You can't see it, but you see a nice jet bony spur there.
True.
Getting out in the lower lumbar region. And it would be interesting to see that in an axial view. But the striking feature here is that the neck is quite narrow. It's not like an open neural tube defect where you have a very wide spinal canal connecting with the defect. The base seems very narrow. So that possibly could be the reason why you do not have so many intracranial changes. There could be some sort of valve mechanism, a very narrow neck preventing the pressure to fall, and therefore you're not seeing so many intracranial changes. Just a postulation, I'm not sure. But this is a striking feature here. The neck appears quite pinched out. You don't really see the communication with the spinal canal too well here.
True, true. So, Dr. Rima, next slide, if you can.
Yes.
So, as you described, is it possible to have spinal defects without cranial findings, or is it common?
Extremely rare. As I said, I'm just trying to postulate the reason why you have a defect here. Yet the only possibly explanation is the cisterna magna is too small. But again, I believe this is extremely rare to have no intracranial effects. The only possible explanation exists in the fact that the neck is quite narrow there, not obviously connecting with the spinal canal, and that explains. So the moral I would say of this case is not to harp about the intracranial. It's more about doing a detailed spinal analysis irrespective of what you see in the brain. So you should still see the spine away from the uterine wall, even if the brain is normal, is probably the only take home I would say from this slide. And
Absolutely
this
correct.
finding
Yes.
enough, or should we look for other findings in this case?
Yes. So we
I
saw a
was
bony spur here. Yes.
bony spur. That's when you see a bony spur, I'm concerned about a diastematomylia. When there's diastematomylia, I'm concerned about splitting of the cord and a low-lying cord. Both of them go hand in hand. So I would look out for the conus there, and I would look out for a splitting there. That is, see it happening in the axial view. In fact, if the spine is anterior, you can even use a linear to depict whether the cord is getting split there. And here you've already labeled that. And the cord, where is the cord ending here? Can you just guide me here? I can't really see it on my monitor well, but I
Yes.
believe this is the conus, right?
Yes. Yes. This is the
Beneath
conus.
the spur,
Yes.
much beneath the spur.
Yes. And we can see the splitting of the cord. You can even see it in the sagittal plane.
Yes. So when I see a cord which is tethered, I would also look for an intraspinal lipoma that also goes hand in hand with tethering. So I will going to see for any echogenic fat containing mass lesion down there under the skin and compressing the cord that goes very often hand in hand with a tethered cord. So here it is a diastematomylia with splitting and tethered cord. And generally, when the cord is more dorsally placed in the spinal canal. And that is again a very striking feature that you can see that in the sagittal view. If I'm not mistaken, if you could just highlight that, it's beautifully seen that is more dorsally placed within the spinal canal. And this is an excellent case.
Yes. So this was actually very young. So this was just less than 19 weeks. So the spinal cord, it was not very easily to see. But still, we can see the bony spur, we can see splitting of the cord, we can see the tethering also in that
Right.
case. Dr. Rima, next slide. So this has been done already. So this was a case of a meningocele with diastematomylia type 1. There were hardly any cranial findings because probably the defect was very small. The open defect was very, very small. Next slide. So, Dr. Anurag, what is the prognosis in such cases? Is it better? Is it worse than the open spina bifida?
So if we see, how it happens is that the closed neural tube defect, they fare slightly better outcome in the sense than the hindbrain herniation does not happen. The whole uh, the theory is that because of the some sort of action which is created because of loss of CSF happening, the hindbrain descent and it happens. So it would be slightly so to closed neural tube defect would be slightly better than open spine bifida.
Thank you so much.
So thank you so much. So what we need to understand is that a mid-trimester scan is very important. We must look at the first trimester intracranial signs, which Dr. Khurana brought about. We must look at the second trimester intracranial signs. We have to take a detailed history of whether mother has diabetes, she's on anti-epileptics, she's obese, or and of course, look closely for the fetal limbs, whether if you find CTEV, look for the spinal signs, look for any lesions that we may be missing out on. but we also need to understand that there's multifactorial in origin, and we cannot pinpoint, but yes, folic acid is very, very important to prevent the neural tube defects. So from today's panel, our take-home message is that in today's era, it's almost 100% detection in the anomaly scan. We cannot afford to miss a spinal defect. It's from the first trimester. If we still miss second trimester, we cannot be forgiven for missing a spinal defect. Prenatal in utero surgery is an option. Some centers are working on it, and hopefully in the near future we will have an answer, and in utero repair for meningomyelocele repair. Prognostication of the lesion is very important for the parents. We need to tell them how their baby will behave once the baby delivers, the surgery that will be required. It's a team effort. A neurosurgeon, pediatric neurosurgeon, a pediatric surgeon has to be on board to try to explain and counsel how we are dealing with these babies. And first trimester, as Khurana sir said, gives us clues. We need to look at these intracranial signs and spinal signs carefully. Thank you so much. Thank you to my wonderful panelists and co-moderator for this panel. Thank you.
Thank you everyone joining us. Hope we could give some take-home points, or Dr. Khurana says take to work points. Khurana sir, if final comments, if you can.
Yes, we still have a few questions though in the panel box, but there's a bit of an angle that I want everybody to understand, that yes, there are teams that are just ready now to actually do fetal surgery for us in our part of the world. I know Karan Rima's team is now absolutely set. They've already practiced on the simulator. They've had experience in South America and in other parts of the world, and they're pretty much sure that with Dr. Anurag Sharma on their team, we should be able to do this. Our biggest problem when it comes to spina bifida remains the fact that most of our patients at any stage would actually opt for terminating these pregnancies, because we've made our laws so liberal, and also because our social support from the community, not from the government, but from the community, is not forthcoming. And we still have horrible words like langada and lula, which are going around in our language, which children are not taught the sensitivity for in our schools. So we do need that social revolution, but we do need the patience as well. The second thing is that, yes, it is a lot easier to do open repair, but whenever we've done a hysterotomy, the incidence of dehiscence of hysterotomy scars is fairly high in a second or a third pregnancy. And therefore, from that angle also, we need to move to try and understand that we must try and do fetoscopic surgery and do that, and then or rapidly move on from open surgery to fetoscopic surgery. The third question that arises is how much of the lesion should we actually repair at the time of antenatal surgery? So when it comes to prenatal surgery, the aim really should be not like in the older years, 5 years, 6 years ago, when we used to just try and cover the defect. The aim really now is to do definitive surgery, unless you find a lot of fat in the lesion. If we find fat in the lesion, we know for sure that we'll have to reoperate after baby arrives. But otherwise, when it is the simple ones without fat in the lesion, and this is where MRI plays a large role in planning our surgery, we will then do a fetoscopic, almost complete kind of surgery to make sure that the recovery is as complete as possible, and perhaps the baby may not even require postnatal surgery. So these are some of the points that we have to keep in mind. We have a long way to go, but the good thing is at least we've reached there. And I'm reasonably sure that we will have patients, and with SFM leading the front as we are today, we'll have patients whom we can share experience, and we can have people coming into India to do surgeries for us, rather than us having to go there to learn surgeries from them. Because even when we go for training to centers abroad, sometimes for a whole month I've sat there waiting for the patient, and the patient never came really. So we never got to see a surgery. So we'll have to learn on our own patients, and this is the only way forward that we can do. We must, of course, also, before I close, answer some of the very simple questions that are here. And one of the questions that I thought we needed to address was this word called the limited dorsal myeloschisis. It's a word that came into literature, and I don't know what the panel thinks about it. Anybody on the panel would like to tell us the difference between a limited dorsal myeloschisis versus just a completely a myeloschisis? A myeloschisis, yes, we know is different from a rachis, but whether it's a 1 centimeter to 3 centimeter, it really means the same thing.
I think Anurag sir can better tell us about LDM.
Yes, so LDM is it's a relative later terminology. I think it was coined somewhere in 2008 or somewhere around that time.
That's right. Yes.
Right. So earlier it was not. It was earlier caused as dorsal meningomyelocele. Now the management principle, it's separate, because when you say it's limited dorsal myelocele, then it's a whole. The defect is actually the cord. Right. So the cord is coming. So the surgical management becomes slightly tricky, because then you have to go up, you have to define the cord upside, you have to define the cord downside, free it from outside, and give it a proper covering. It's very different from there's no dura, So if you try to go, you'll end up bang on the spinal cord. So if you don't know this entity, as a neurosurgeon, it would be a crime to be operating, because you are going to harm the patient, and then because the level is very high, then you surely are going to cause deficits.
Yes, and even if the dura is there, sometimes it can be so thin and wavy and corrugated
you cannot define
that you cannot define it. Yeah. There's also one interesting question that needs to be answered, and that is from Ruchika Sood. If 2 fetuses affected with neural tube defects, what investigation should we offer to the couple?
I think we must do a VES in that particular case, because there have been, like I mentioned, there are certain candidate genes which have been identified, and we normally do offer that. And we had a recent case series of 5 patients in which 2 of them were identified on VES. So I think if there are more than 1, like I mentioned, it is important that we offer VES, but of course keep the geneticist in the loop to understand that it's not a variant of unknown significance. But yes, I mean, that's something that we need to keep that in mind.
Yeah. And in that situation, of course, the interpretation can be so tricky that we would always do a trio sequencing to start with. And then if that does not yield anything for us, then we start finding out whether there are some other groups of genes that might be actually affected in that particular couple. So it's not that we will not do any genetics. What Dr. Parna was referring to during the panel discussion was that in a random case with one odd event, we don't require too much of genetic evaluation. Bimal, any words from you?
Actually, I think you guys have been so good that this is the first time I'm not seeing any questions. Everybody's understood everything. And the second thing is, I think the crux of the matter from this whole panel is that, like Aparna said, that the only way to, I think prevention is better than cure, and the only way is folic acid. So there are about 200 people logged in. So one message I would like to give is that, it's always preconceptional folic acid, but then we moved on to let it be a marriage pill. But I would say that we should call it as an engagement pill. Like if any friend of yours calls up and says that my daughter has got engaged, congratulate them later, but first thing, tell them, have you started her on folic acid? That's the way it would really work up, because that is because we have such a high incidence of neural tube defects in our country. And if a simple small pill can make a difference, it's just about creating that kind of an awareness, and not just amongst the doctors, but amongst the patients also. So I think if all of us do this, make it a point that congratulate them later, but first tell them to start on folic acid.
Excellent. And we'd like to close today's discussion with an announcement that Dr. Chinmay Umarji is going to make. We have an SFM fetal surgery workshop coming up in Pune in December. Chinmay, could you let us know the dates and the structure of the program?
Thank you so much, Khurana sir, for the opportunity. And I, on behalf of SFM Pune, take great pleasure to invite all of you to this workshop, which sir mentioned. We'll be doing this on 21st, 22nd, and 23rd of December. A very exclusive workshop for fetal twin complications and surgery. 2 days of extensive learning about complicated monochorionic twins, and the third day on mannequins. And we've got excellent faculty. We've got international faculty like Professor T.Y. Leung, who is coming down from Hong Kong. We've got Aparna Sharma ma'am, Chinmay Rath ma'am, our mentor emeritus, Ashok Khurana sir, guiding us all throughout. And this is a very focused class and workshop where we have very, very limited seats. The total number was 40, and I'm proud to say that we are already down to 20 registrations. So we're doing a good job.
Thank you. That's fantastic. And we look forward to the December workshop.
Thank you, sir. Thanks a lot.
And with that, we come to the end. My special thanks to Mohit for leading this Spina Bifida Awareness program. And we will continue to practice this not just in October, but November, December, etc. as possible. And of course, to Rima and to Alok for the panel discussion, and to all our panelists as well. Aparna, I saw your hand go up. Did you have anything special to add?
No, I thought I'll just say this before the final words, but I thought,
Yes.
fine. No, sir, I think like what you have mentioned is that it is time that we are aware of prenatal surgery. We get aware, seriously get aware, and we start referring patients to centers that would like to offer therapy. And I think this day is the day when we declare that, yes, we must think of prenatal repair in a very serious manner. I think that's what is missing. It's not really easy to find patients, as you're saying, everyone goes for termination, but there would be one odd patient who would want to continue pregnancy and improve prognosis. So I think that is something that we must put across to this audience and to SFM in general, that if you find patients, time to refer.
Excellent. And now we have referral patterns in place, and you can be in touch.
Who else other than SFM to take it up?
Absolutely true.
So true.
Yes. So there's a request from Dr. Chandramohani to provide a list of hospitals where we're trying to develop this facility. Of course, the All India Institute of Medical Sciences, New Delhi, as well as led by Dr. Vatsala, Dr. Aparna and her team. And of course, Colonel Rima Bhatt and her team at Amrita in Faridabad, where really speaking, I've gone and actually seen the kind of work they've done on the mannequin when they were doing their last sort of checklist thing. And we pretty much set there as well. And the rest of it will keep flowing. I think 2 centers to start in the country today would be absolutely fantastic, and the patients can be moved very easily. And we will then, of course, invite everyone else who is trained anywhere in the world to join hands with anybody with SFM to go ahead and keep us informed. You know, we communicate a lot on our WhatsApp groups, and we'll be able to communicate the fact that, yes, you are now beginning to start this exercise, and therefore we can make use of it. So on that note, thank you very much. And it seems that we can then happily look forward to a much brighter future for Spina Bifida. Thanks indeed, and a very good night.
Amen.
Good night, everyone.